Hello everyone, welcome back to my channel, that is Obstetrics and Gynecology Simplified. Today we are going to discuss about a very important topic, the most common symptom that patients come to the gynecology OPD, that is the genital infections. Okay, so infections of the genital tract. As we know that genital tract consists of external genitalia as well as the internal genitalia. Both can be infected. The most common, okay, first we should know that the genital tract consists of, first, from the outside to inside, that is vulva, vagina, cervix, then uterus, then fallopian tubes. Also the ovaries can be infected. Okay, so these all constitutes the infections of the genital tract. And when the infection occurs, there the most common symptom, okay, the most common symptom is the vaginal discharge. Okay, that is the white discharge or any color discharge. That is the most common symptom. So what are the organisms that are involved? It may be bacteria, it may be virus, it may be parasites. Okay, and so first we will know about the normal characteristic of the vagina, how the vagina is protected, what is the normal pH, what is the normal flora of the vagina, and when the infection occurs, what changes occurs, what are the changes, what are the hormonal changes, what are the floral changes, how does the pH changes, what does it looks like, what are the symptoms, what are the signs, and what are the treatment. Okay, so let's start coming to the characteristics of the normal vaginal tract. So in females it is lined by, in adult females it is lined by stratified squamous epithelium, and in newborn it is lined by transitional epithelium. So see, what does stratified squamous epithelium does? See, stratified squamous epithelium, as there are multiple layers, so it acts as a barrier or protective layer to prevent the organisms to go inside or invade the vagina. Okay, so it acts as a protective layer, because the stratified means there are multiple layers of the squamous epithelium, that is stratified squamous epithelium. So this stratification helps to prevent the organisms to enter into the basal layer of the vagina. So what does stratified squamous epithelium do? Stratified squamous epithelium, it is resistant to both gonococcal and chlamydial infection. So these two infections cannot occur in adult. But in newborn, as the vagina it is lined by the transitional epithelium, so there are more chances of invasion of the gonococci as well as the chlamydia. So the most common site for, what is the most common site for gonococcal infection? It is the, in young females, most common site for gonococcal infection in young females is endocervix. Why? Because endocervix is lined by columnar epithelium. Okay, it is lined by columnar epithelium. And what is the normal flora? The normal flora of the vagina is, Doddelins bacteria, Dodder, Tordelins bacillus. How does it helps? See, Tordelins bacillus, it is the normal flora in the vagina. How does it helps? It helps by converting the glycogen in the epithelium, glycogen to lactic acid. Okay, it converts to lactic acid. And what does lactic acid does? It is acidic in pH, acidic in pH, and hence it protects the vagina by creating a acidic barrier, acidic barrier. Okay, understood? So it acts as a barrier for the external organisms and hence protects from the infection. Okay, so what is the characteristic of the physiological discharge? If a patient comes to the OPD and she complains of white discharge, so you have to counsel, you have to know that it if it is physiological or it is pathological. So what is the characteristic of the physiological discharge? It is clear, the discharge is clear, white, okay, flocculent, odorless. Okay, and when it comes in contact with the air, it turns yellowish, yellowish, light yellowish when comes in contact with air. Okay, understood? Due to oxidation. Okay, this is a question. Okay, due to oxidation. Then see, if we take a smear, see what we have learned, that it contains of Dodderlin's bacillus as well as the epithelial cells, that is the squamous epithelial cells. So the smear contains, if we take a vaginal smear, smear contains epithelial cells plus lactobacilli. Okay, and the pH is acidic. I've told you what is the normal pH, 3.8 to 4.2. It is the normal pH, and this is very, very important. We have to remember this, what is the normal pH of the vagina. And when the pH is increased, increase in pH of vagina in pregnancy due to the effect of estrogen. Okay, so pregnancy, okay, pussy pills, premenarche, and also mid-cycle, and also in PCOS. Okay, so these are the conditions where the pH of the vagina is increased, okay, due to the effect of estrogen, and there is decrease of the pH. So now coming to the, so these are the characteristic of the normal physiological discharge. And what about the infection or the pathological? See, what are the types of vulvovaginitis? Vulvovaginitis means there is infection of the, see, itis means inflammation. Okay, so inflammation of the vagina and vulva. Okay, so this means infection, vulvovaginitis means infection of the genital tract, that is vulva and vagina. So what are the types? Types is two types. First, either infective cause or non-infective cause. Non-infective causes. So infective cause, we know, first due to bacteria, that is bacterial vaginosis. Then due to fungus, that is candidiasis. And then due to what? Parasite, that is trichomoniasis. Okay, and trichomoniasis. And what are the non-infective cause? Non-infective cause like foreign body and senile vaginitis or atrophic vaginitis. Atrophic vaginitis and other causes like lichen sclerosis, and irritant dermatitis or allergic dermatitis. Irritant or allergic dermatitis. Okay, so these are the types. First it is infective cause and non-infective causes. In infective causes there is bacterial vaginosis, candidiasis, trichomoniasis, and in non-infective causes like foreign body, if any foreign body is stuck into the vagina or vulva, then there will be continuous discharge, and that is also pathological. But as there is no infection, so it is a non-infective causes. Okay, and due to senile or atrophic vaginitis, what happens? Due to decrease in the estrogen. Okay, due to decrease in estrogen, as I have mentioned in genitourinary syndrome of menopause, what happens? There is atrophy of the vaginal epithelium, and there is increased chances of infection as the layers, that is the stratified squamous epithelium, that is decreased. Okay, so there is more chances of infection and more chances of invasion by the bacteria. Okay, even after it is not see, senile or atrophic vaginitis, it is not infectious, but due to decrease in estrogen level, due to thinning of the vaginal epithelium, it is more prone to injury, and when injury occurs, there is white discharge, and also it may be associated with other infective causes of vaginal or cervical discharge. Okay, and then see, so about senile vaginitis, what we learned, that it is due to see, this happens in postmenopausal women, and it is due to decrease in hormones, estrogen. Okay, and what are the clinical features? Dryness, okay, and discomfort, dyspareunia, and thin pale mucosa, thin pale vaginal mucosa, and recurrent UTI or dysuria. Okay, so these are the clinical features. How will we investigate it? We will do, see, in per speculum examination. Okay, what is per speculum examination? We put speculum, see, if this is the lateral vaginal one and this is the cervix, this is the internal os. So here we put speculum, okay, and retract the posterior vaginal wall. This is the posterior vaginal wall. We retract, okay, we retract, and then we see we examine the lateral vaginal wall. This is the lateral vaginal wall, this is the cervix. Okay, we examine. So this is the per speculum examination. Okay, in per speculum examination, we see thin pale mucosa, thin pale mucosa, and erythema, dry, dryness of mucosa, thin, pale, dry mucosa. Okay, and what is the treatment? We give local estrogen. Local estrogen, that is the Premarin. Local estrogen cream. Okay. Also, we can give oral or transdermal HRT, but that is not more effective as that of local estrogen. Okay. Oral or transdermal HRT. Details about HRT or hormone replacement therapy I have discussed about in menopause and HRT. You just go and watch there. Okay. Then coming to the infectious vulvovaginitis. See, I've told you one due to bacteria, one due to candida and one due to trichomonas. So, what is the organism? First, Gardnerella vaginalis bacterial vaginosis is due to Gardnerella vaginalis, and candidiasis is due to Candida albicans. Candida albicans, Candida glabrata and Candida tropicalis. And trichomoniasis is due to Trichomonas vaginalis, which is a flagellated protozoa. Okay, and most commonly it is found in, see, bacterial vaginosis. It is overall, this is most common. Okay, bacterial vaginosis, most overall, most common type of infectious vulvovaginitis is overall most common. Okay, vaginitis is bacterial vaginitis. And here in candidiasis, most common vaginitis in immunocompromised pregnancy. Pregnancy is also an immunocompromised state. Okay, so pregnancy, then diabetes, other immunocompromised conditions when we take steroids or ocipills, diabetes and immunocompromised ocipills users, and also antibiotic and steroid. So here in these cases it is most common. Okay, so what is the pH in bacterial vaginosis? Remember, in candidiasis only the pH is acidic, that is less than 4.5, but in bacterial vaginosis as well as trichomoniasis it is alkaline. Okay, so it is more than 4.5. Here also more than 4.5, that is 5 to 6 pH. Okay, then what is the most common complaint in bacterial vaginosis? See, it is non-inflammatory condition. So, there will be no itching, but there will, due to the presence of bacteria, there will be foul smelling discharge, but there will be no itching because there is no inflammation. So, foul smelling, it will be foul smelling, but there will be no discharge, as there is no, no, it is no discharge, there will be no itching. Okay, there will be no itching because there is no inflammation. But in candidiasis there will be intense pruritus. Okay, also at night time there will be so much pruritus that also in night time patient will not be able to sleep because of the itching. So there will be intense pruritus. intense pruritus, and the discharge is curdy white. Curdy white, it is very typical of candidiasis, that is curdy white discharge. Okay, and there will be splash dysuria. Okay, and here in trichomoniasis, it is, there will be profuse frothy greenish yellow discharge. Greenish yellow discharge. Also there will be dysuria and dyspareunia. It is a STI, okay, sexually transmitted disease. That means we need partner treatment when we are treating trichomoniasis. Okay, then what is the signs? See, no change in vaginal epithelium or cervical epithelium, but here in trichomoniasis there will be multiple hemorrhagic spots. So it looks as like strawberry. So there is strawberry vagina or cervix due to multiple hemorrhagic spots. That is also called as angry looking vagina. I will show you a picture. Also I will show you the curdy white discharge. See, in speculum examination we are seeing, see, this is the, see, this is angry looking vagina. These are the multiple spots. Okay, see, hemorrhagic, multiple hemorrhagic spots. So this is strawberry vagina. Okay, understood? This is strawberry vagina. And see, this one is the curdy white discharge. The discharge is curdy white. This discharge, this is the cervix. Okay, this white portion, these are the discharge. So curdy white discharge. Okay, this is specific in candidiasis, and this strawberry vagina, it is specific for trichomoniasis. Okay, then coming to signs. Okay, strawberry vagina or strawberry cervix I've told you, also called as angry looking vagina. Then what happens in candidiasis? In candidiasis there is erythema and edema of labia and vulvar skin. Okay, then what is the investigation of choice? We do saline mount or saline microscopy. In saline microscopy, what we see here, very specific clue cells, that is normal epithelial cells to which the bacteria are attached. If this is the normal epithelium, okay, epithelial cells, this is the normal epithelial cells, when the bacteria are attached to it, bacteria are attached to it, that is clue cell. Okay, so see, clue cell I'll show you. See, this is the clue cell. See, this is the normal epithelial cell. Okay, this is the normal epithelial cell. Here to the epithelial cell, when multiple bacteria, this one is the multiple bacteria that are attached. Okay, that is called as clue cell. Okay, understood? So it is present in bacterial vaginosis. Okay, in saline mount. And see, this is the trichomonas vaginalis in saline smear of the vaginal swab. These are the pus cells. Okay, these are the pus cells. Okay, these are the trophozoites of trichomonas vaginalis. Understood? This is the saline mount picture of the trichomonas, and that was the saline mount picture of the what? Bacterial vaginosis. And in candidiasis, we see pseudohyphae. As it is a fungal infection, we see pseudohyphae, and in trichomoniasis we see motile flagellated trichomonas. Understood? So, see, this is the investigation of choice. Okay, means we do, this is the choice. But what is the gold standard investigation? In bacterial vaginosis, the gold standard investigation is gram stain. Okay, in gram stain, we do Nugent scoring system. We use Nugent scoring system to confirm about the bacterial vaginosis. And what is the gold standard for candidiasis? We do SDA culture, Sabarod, dextrose medium. Okay, SDA medium is used for candidiasis. And for what is the gold standard investigation in trichomonas? In trichomonas, the gold standard investigation is what? Culture on Whittington Finberg, Whittington media or diamond media. See, also you can remember like this as white diamond. Okay, so Whittington media and diamond media. Okay, white diamond we can remember is, okay, white diamond, just a mnemonic to remember. Okay, then we can also do amine test or whiff test. What we do in amine test or whiff test? We add 10% KOH to the white discharge. Okay, plus white discharge. Then what we do? We smell. Okay, if there is amine smell or amine like odor, then that means there is bacterial vaginosis. And there is no amine odor in candidiasis, but in trichomoniasis there may or may not be. Why may or may not be? Amine odor, if trichomoniasis is associated with bacterial vaginosis, then there will be amine odor or whiff test will be positive. But there is negative whiff test if there is presence of isolated trichomoniasis without the presence of bacterial vaginosis. Okay, if no bacterial vaginosis. And what is the treatment? See, treatment is very simple. We give tablet metronidazole 500 twice daily for 7 days, or cream also we can give for 7 days. Which cream? Clindamycin 2%. What about candidiasis? We give antifungals, that is fluconazole 150 milligram single dose. These all in uncomplicated case. Okay, and for trichomoniasis also we give metronidazole 2 gram single dose, or we can give 500 BD, okay, for 7 days. In pregnancy, can we give metronidazole? Yes, we can give tablet metronidazole, but in 250 milligram TDS for 7 days. And what about trichomoniasis? Same, tablet metronidazole 250 TDS for 7 days. And what about antifungals? We give topical azoles. Okay, these are, we don't give, we avoid topical azoles are avoided in, all these are avoided in first trimester. Okay, in first trimester we avoid. Okay, Then coming to hazards of bacterial vaginosis. Okay. Then coming to the hazards of bacterial vaginosis. In women with bacterial vaginosis, they have a increased risk of, in women with bacterial vaginosis have increased risk of PID and post-abortal PID, post-abortal PID, then vault infection. What is vault? That is in post-hysterectomy patient, hysterectomy patients, the vaginal vault infection that can occur in women with bacterial vaginosis. Okay, they have increased risk. And in pregnancy, what happens? In pregnancy, there is increased risk of premature rupture of membranes. Okay, increased risk of PPROM and PROM, and increased risk of chorioamnionitis, preterm delivery, increased preterm delivery, and post CS endometritis, increased endometritis, post delivery or post cesarean section. Okay. Then, what are the things we must know about candidiasis? See, candidiasis may be uncomplicated or complicated. Uncomplicated, uncomplicated, or complicated. In uncomplicated, what we mean that it is uncomplicated is sporadic, okay, and only mild to moderate severity, moderate severity. But in complicated, it is recurrent and severe. What about the species that is involved in uncomplicated? In uncomplicated, it is Candida albicans, while in complicated, it is non-albicans species. Okay, then what about this occurs in unimmunocompromised patients, unimmunocompromised patient. Whereas in complicated candidiasis, most commonly it occurs in immunocompromised. And needs longer treatment. Longer treatment. Okay, it is 7 to 14 days. What is recurrent vulvovaginal candidiasis? Recurrent vulvovaginal candidiasis. In recurrent if there is more than equal to 4 episodes of vulvovaginal candidiasis in a year, that means it is called as recurrent vulvovaginal candidiasis. And what is the treatment? We give fluconazole 150 milligram, 3 doses, and then weekly for 6 months. Okay, this is for albicans species. For non-albicans, recurrent vulvovaginal candidiasis, we use boric acid gelatin capsules. Boric acid gelatin capsules intravaginally. Okay, for treatment. Okay, so this is it for this video. In next video we will be studying about PID. Okay, that is the infection of the internal genitalia. So keep learning, and if any doubt, go ahead and ask the queries in the comment section. Thank you so much.